Okay, I'd like to talk to you about avascular necrosis of the femoral head. This is going to be a fairly pragmatic talk. There are some extra bits of reading that you might need to do to look up some of the references and some of the basic science, but hopefully this will cover everything that I think you will need to get through your exam viva and also actually for your day-to-day practice if you become a hip surgeon. So, if you're asked to talk about avascular necrosis of the femoral head, the basic winner way to do it is to go back to the old surgical and mnemonic: incidence, age, sex, geography, predisposing factors, macroscopic, microscopic, spread, prognosis. The so-called inner surgeon's glove. Physicians might make some progress. And then just add in all the facts that you need to know about AVN in that regard. So in terms of avascular necrosis of the femoral head, about 2,500 cases per year in the UK. It's a disease mainly of males between 30 and 50 years of age. It's a disease of the Western world largely. Predisposing factors: alcohol, steroids, trauma, smoking, blood disorders, particularly sickle cell, and lipid storage diseases such as Gaucher's, radiotherapy, chemotherapy for cancer, HIV, and then this group of idiopathic, which essentially means, I think, you don't know what the cause is. There is a cause, you just don't know what it is, rather than there is no cause. In terms of the differential diagnosis, you need to know about transient osteoporosis of the femoral head, which affects two groups: pregnant females and men, generally older than the AVN group, so men in their 60s and 70s who present with acute severe pain in the hip. And when you do an MRI scan, the femoral head lights up like a Belisha beacon. That's transient osteoporosis. That's a self-limiting condition and different from avascular necrosis of the femoral head, which will progress. Transient osteoporosis generally doesn't. So coming back to avascular necrosis of the femoral head, macroscopic pathology is death of bone and collapse of the femoral head, initially leaving the cartilage normal, but as the cartilage loses its structural support, it will also fail and fall off, and of course then arthritis is the final result. Microscopically, the osteoblasts, the osteoclasts, the osteocytes, the marrow cells, they're all dead, and there is a loss of the trabecular structure of the bone. Eventually you'll get reperfusion, and microscopically when reperfusion occurs, you'll see angiogenesis, and if you biopsy the tissue at the edge of an AVN infarct, you'll find granulation tissue. So the idea is that all avascular necrosis will eventually heal. It's just, it generally tends to collapse before it can heal, and so the final result is arthritis. But there is continual attempts at healing, and that's why there's granulation tissue at the edge of the infarct. The prognosis, of course, depends on the stage, the grade, the underlying pathology, and the treatment that you decide to embark upon. So here we go. We're going to show you three X-rays which really sum up avascular necrosis. Here's the first one, and here's the classic wedge-shaped infarct that we see in avascular necrosis. This is a huge infarct, but classically wedge-shaped. And the reason you get that is, and the reason certain parts of the body are prone to avascular necrosis, is because you have a retrograde blood supply with end arterial dominance. So here we've got a retrograde flow of an end artery, which gets to about here, and then it fans out to supply a territory of bone. So if the end artery gets blocked somewhere down here, then all of the area that is supplied by the fanning out of vessels from the end artery will be affected. So small area here, progressively getting bigger as we go further away from the blockage of retrograde flow in an end artery. Next is the crescent sign. This is when you get an area of subcondylar collapse, so that the periphery of the femoral head, and particularly the cartilage, which of course you can't see on an X-ray, but that will be normal. But underneath, the subchondral bone, which is dead, is starting to collapse away, and it gives you this double shadow. That is an absolutely textbook crescent sign. And here you see what's going on histologically, where the subchondral bone is collapsing back from the cartilage, and that gives you the double shadow on an X-ray. And finally, of course, the end result is a worst case scenario is complete destruction of the femoral head and severe osteoarthritis. We don't want to get to that stage if we can help it. So what is actually going on in avascular necrosis? What's the underlying pathophysiology? Very interesting, actually. And the original work was done by Fecat and Arlett. And what they did was they put a pressure transducer into the femoral neck and tried to work out what is going on. And they found that this is a pressure-related phenomenon. So these are not the original Fecat and Arlett curves. I couldn't actually find them anywhere, but these are very similar, and they actually represent the same phenomenon. So if you put a pressure transducer into the femoral head and you set the resting pressure at 0 here, and then at a certain stage you inject a certain known volume of saline into the bone, the first thing, of course, that happens is the pressure goes up very quickly, and then slightly less quickly the pressure will ebb away, and then you get back down to your resting pressure again. So that is the so-called forage of bone experiment that Fecat and Arlett performed. And we subsequently know that how the pressure increases changes with the rate of the flush duration. It stands to reason, really, but this highlights that there is a functioning venous outflow channel from the bone. Because if you inject very quickly and you momentarily exceed the venous outflow capacity, you get this very significant increase in pressure. Whereas if you flush the same volume but much slower, you won't increase the venous outflow capacity, and so the pressure doesn't go up very much. So that's the normal situation. And Fecat and Arlett found very predictable abnormalities in patients with avascular necrosis of the femoral head. And that was that the resting pressure, the baseline pressure, was higher than compared to their controls. And then when you inject the same volume of saline, you get a higher peak pressure and you get a slower settling back down to that original higher baseline once again. And they inferred, and I think correctly, that therefore that the underlying pathophysiology was one of venous obstruction, and this makes it rather analogous to compartment syndrome. We know now that this was a correct hypothesis, and actually it's in some way due to abnormal lipid metabolism, which leads to venous hypertension, blocking of the veins, and obstruction of outflow. It's quite an interesting subject if you want to go and read more about it, but you certainly won't need any more than that for your exam. So all compartment syndromes are the same, aren't they? It starts with obstruction of venous outflow, the pressure goes up, that eventually overcomes arterial inflow pressure, and then you get necrosis. Well, that is what we're dealing with here in avascular necrosis, and Fecat and Arlett were really the first people to work that out. So really then, that makes core decompression the sort of fasciotomy of the bone, and I've always thought of it like that, and I think it's still entirely reasonable to think of it like that. As we'll talk about in a minute, you can try and stimulate some healing in several ways, actually, but the basic principle, I think, is you're just simply making a hole in the bone and allowing the pressure to dissipate more quickly, which frees up the outflow, which means that the inflow is less challenged, and that allows the arterial inflow to bring more oxygen and healing potential to the area. So I think it's entirely reasonable to think of avascular necrosis as a compartment syndrome of bone, and the core decompression as the fasciotomy. So if you are in an exam viva and you've got to this stage, you are flying, because I would imagine that most of the examiners will not know the sort of knowledge that you just imparted to them. But the next thing you will always get to is a discussion of staging, because of course prognosis and treatment is stage dependent, and it's only right that you should have a plan and a knowledge of how to stage patients who present with avascular necrosis. You will be expected to know the FECAT and ARLAT staging system: 1, 2, 3, 4. 1, normal X-ray. 2, sclerosis but no collapse. 3, collapse, that's the crescent sign. And 4, advanced arthritis. Of course, FECAT and ARLAT didn't have an MRI scan, so it's subsequently been slightly refined. And in fact, a stage 0 has even been added by certain authors, where it's an entirely normal hip, but the patient's got avascular necrosis on the other side, which gives a nod to the fact, as we said in our earlier mnemonic, that it's very frequent if you have it on one side that you'll get it on the other side. And then on stage 1, whilst the X-ray is normal, the MRI scan isn't. And then, of course, there are changes that you see in the MRI scan progressing through to advanced degenerative change, where, of course, nobody needs an MRI scan to diagnose arthritis. There are, however, some problems with the FECAT classification, and I would expect you to know how to criticise it. First criticism wasn't really their fault, because, of course, MRI was not available. But the main problems really are that the FECAT is just a one-off diagnosis, which doesn't really help in many ways. First of all, it doesn't describe the location of your necrotic segment, and clinically, your necrotic segment will behave very differently if it's on the non-weight-bearing surface of the femoral head compared to if it's on the weight-bearing surface of the femoral head. And of course, then we go on to the amount of femoral head that's involved, and it stands to reason that 80% of the weight-bearing surface of the femoral head will fare much less well than 5% of the non-weight-bearing surface of the femoral head. So FECAT, whilst original, and we all come back to it always, got to bear in mind all the time that it just doesn't describe the location, and it doesn't describe the amount of femoral head, and so is limited in clinical practice value. So there are some other classification systems, and you might want to remember the labels. I wouldn't ever expect you to remember the detail, but perhaps the label and what they refer to. So the Steinberg classification attempts to quantify how much of the femoral head is involved. And of course, the flow through the classification from stage 0 to stage 6 is exactly the same, going from a normal X-ray to advanced arthritis. But in 2, 3, 4, and 5, there is an attempt at least to define how much of the femoral head is involved. I rather like this. This is the Kerbuhl combined necrotic angle. So you look at the MRI scan in 2 planes, and you add the necrotic angle from the 2 planes, and that gives you a number, and that number can be classified as small, medium, or large, depending on how much. And the combined angles will, of course, just define how much of the femoral head is involved. So a big number is bad, a small number is less bad. I rather like that, and it's quite easy to remember, I think. This is the one that I used when I was coming up to the exam, so it's obviously extremely old now. But it was, I think, one of the first classification systems that gave nod to the fact that you had to try and define how much of the femoral head is involved. University of Pennsylvania classification system, and it was using angular measurements and 3D MRI scan. And I think perhaps this one is, if you want to remember 2, I would remember FECAT and ARCO. And again, I'm not entirely sure you need to know the details, but at least the ARCO International Classification of Avascular Necrosis tries to combine the size of the lesion, location of the lesion, and the degree of arthritis. So this is, if you like, the Rolls-Royce classification system, but extremely difficult to remember when you're trying to remember hundreds and hundreds of different classification systems. But nevertheless, I would try and commit to memory VCAT, one classification system that attempts to define how much of the femoral head is involved, and then ARCO, which tries to combine the amount and the location, for the reason that lesions in the weight-bearing area will tend to be more symptomatic and more vulnerable to collapse. In terms of treatment of avascular necrosis, it really depends, in my opinion, on the stage and the etiology. We need to understand the natural history of the lesion that we are presented with before we can embark on treatment. And for that, I would go and have a look at the original papers from Hungerford. He really gave his name to working out the natural history of avascular necrosis, and his original papers are excellent. There's many, many more, a lot of them from Southeast Asia, and a lot of them employing more complex classification systems, and that makes it very difficult to remember. But if you go and look at the Hungerford papers, they will give you a very good idea of the progression, and the idea that the prognosis will vary a bit according to the stage that the patient presents with. In terms of treatment, bisphosphonate is a very wordy slide. You don't need to worry too much about the details, but this chap, Garwala, has done some research recently. Obviously, bisphosphonates have an inhibitory effect on osteoclasts. So the idea is, can we switch off the osteoclasts and give the osteoblasts a chance to catch up? Quite a seductive idea. Not sure it's absolutely a viable prospect, but nevertheless, there is very good evidence, I think, now that bisphosphonates in the early stages are excellent at relieving pain, and they may, and that's may underlined, have a role to play in slowing down progression. And you'll see from these papers that Garwala reports healing of avascular necrotic segments, which may have been either helped by the bisphosphonates, or the bisphosphonates has in some way slowed down progression, so that, as I described earlier, the natural healing response can become victorious. I'm not sure about that, but I am convinced about the role in terms of treating pain, and you never know quite what's going to happen if patients are free of pain. They certainly might be able to put up with their symptoms much better, especially if they're not a candidate for core decompression, for example. Moving on towards surgical treatment, because the own hyperbaric oxygen really hasn't been terribly useful. I can't really think of any other useful treatments other than bisphosphonates and surgery. So for moving on to surgery, we need to understand our patient. If our patient is addicted to cigarettes, addicted to alcohol, or addicted to injecting him or herself with ridiculous drugs to make their muscles bigger, then I think you've got no chance of any hip preserving surgery working. Similarly, if we're faced with avascular necrosis in this situation, it's hard to believe that anything other than a joint replacement is going to be worthwhile. And if your blood vessels are continually going to be blocked by abnormally shaped red cells or deposits of lipid, then again, it's hard to believe that any joint preserving surgery is going to work. So you have to understand your underlying pathology and structure your treatment accordingly. Someone smoking 80 cigarettes a day, I'm afraid the hip is doomed. Similarly, if they're extremely keen on their JD. Having said that, core decompression is an operation that you really need to know about and have an idea of its use and perhaps its limitations. Very, very early in the disease process, so definitely stage 1, and then with no adverse features. So your true idiopathic patient, not an alcoholic, not a heavy smoker, etc., not sickle cell. Those patients may benefit, and you'll see this from the Hungerford papers, from a core decompression. Having said that, it's very rare. I haven't done one in at least 10 years because it's such a rare presentation. innocent patient with very early disease. Most of the patients I see are sickle cell, but certainly if they're not sickle cell, they have had severe hip trauma, or they had radiotherapy or steroids for cancer. So if you are going to do a core decompression, what are the principles? Well, it's a long straight drill or multiple perforations with cannulated screw guide wires. I'm worried about that because I think that predisposes you to subtrot fracture. So in my hands, it would be a long straight drill, usually the inside of the DHS reamer, under X-ray control on the APN, the lateral, so that you know you are drilling into the necrotic segment. The idea is you try and break down the walls of the segment and maybe disrupt the necrotic segment, encourage some bleeding. And if there is a hole there, you can actually stuff that with bone graft or maybe even growth factors or stem cells. And that's quite an attractive idea. And if you've got more than one segment and you've got a bendy drill, or if you can use the bendy drill to make multiple perforations in one very large segment, then perhaps that's all the better. Treatment of stage 2 is controversial, and like everything in orthopedics, where you get a condition where there are lots of operations described, then the odds are none of them are particularly successful. The idea, if you want to try and preserve the joint in stage 2 AVN, the idea is to try and prevent collapse and allow some healing to occur. But whilst the healing is occurring, you must give some mechanical support to the cartilage, otherwise it will fall off. And if you can bring some healing tissue, some vital tissue in at the same time, then all well and good. So this is the vascularized free fibula graft, popularized by Urbaniak and others. Technically extremely challenging, associated with significant donor site morbidity, and who knows for how long the vessels remain patent. Some people say you do a free fibula vascularized, but all you're actually putting in is a dead strut of bone. But to the converts, it's quite attractive. Of course, you have the opportunity to bring in some viable bone, but the donor site morbidity can never be overlooked. And I'm not aware of anyone in the UK who's consistently performing that procedure. Less biological is to use some form of a strut. And if you use something that the body thinks is bone, then you can get away from the idea of and the problem of donor site morbidity. So as you will know, tantalum looks, feels and behaves like bone in the body. It's strong, and it can be made into these rods which under X-ray control you can insert right up to just underneath the articular surface, with the hope that that will prevent collapse whilst some healing might occur. Of course, you know how well tantalum incorporates, and there are some concerns about this. First one will be, if you've got an infection, how on earth would you get it out whilst preserving the hip? And the second one is, if you come to do a hip replacement, having a fully incorporated rod of rather hard material that's going to be quite destructive to the trochanter as you try and remove it is not the most attractive thing in the world. So there was a fashion for this. People still do talk about it, but again, I'm not aware of anybody who's performing it routinely. Third option was something called the trapdoor procedure, and I think this has completely gone out of fashion now, but when I was a trainee it was quite a popular option. You perform a surgical hip dislocation, you raise the cartilage up so that you expose the necrotic area, you scrape out the necrotic area, pack it with bone graft, lay the cartilage back down and hope that it heals, and hope that you've dealt with the necrotic segment and that similarly heals. But I think all of these operations really gained popularity because we were worried about the success of hip replacement in younger, more active patients. And specifically, as I'll explain, hip replacement got a bad name in the 80s in avascular necrosis. So these sorts of operations became described, performed, talked about, and in certain areas very popular. But as hip replacement has become more accepted as a long-lasting, successful solution, they've all tended to fade away again. If a patient presents to you with stage 3, so you've got subchondral collapse, that patient is going to develop arthritis. There is nothing you can do about it. And the best advice is just to keep calm, wait expectantly, think about bisphosphonates for the pain, tell the patient the journey they're on, and you will come to a hip replacement as and when necessary. Of course, you've got your options of your different orthopedic treatments: excision, arthrodesis, osteotomy, arthroplasty. And in a patient who will never be suitable for an arthroplasty, or if they just won't accept the idea of a joint replacement, then osteotomy, moving the necrotic segment away from the weight-bearing surface, is an option. But imparting any varus on the hip biomechanically, I've never thought was a terribly good thing. And here, if this patient ever comes to hip replacement, that's going to be a very challenging operation. So again, osteotomy has always had some popularity in the Asian orthopedic community, never been a great option, well favoured in the UK. Stage 4, hip replacement. The reason hip replacement got a bad name was because in the 70s and 80s, hip replacement didn't last as long as it does in 2020. And at some stage, there was a feeling that there was something wrong with the bone of the femur, such that you could do a perfect hip replacement in someone with avascular necrosis, and the hip would fall out at 7 years. And there was a feeling that this was something to do with the bone and the bone metabolism. In fact, I'm pretty certain it's not the case. The implants being used at that time were very unsuccessful implants that had a poor track record. And in my opinion, a cemented extostem like this will do extremely well for a patient who presents with avascular necrosis of the femoral head. If the avascular necrosis is associated with complete obliteration of the medullary canal, such as in sickle cell, then that's a different challenge perhaps altogether. But in post-traumatic arthritis, steroids, alcohol, and other etiological factors, then your chosen stem will be fine, and my choice would always be a polished tapered stem for its reproducible results. On the socket side, again, these patients are young and active, and so they will stress your cemented cup fixation to the absolute max. And I think you could very strongly argue that a hybrid hip might be better, because the cementless acetabular fixation might be more durable in the long term in these young and active patients. So, in summary, we need to understand the pathophysiology. Remember FECAT and Arlett's bone forage experiments. We need to be able to stage the patient when he or she presents with avascular necrosis, and we'll do that always with the FECAT and Arlett staging, and then try and add to that some idea of the amount of femoral head and the location of the necrotic segment. We then turn to treatment. Bisphosphonates might help with pain and give us some hope. Very rarely we can treat the true idiopathic patient with core decompression, but in my experience, we basically give bisphosphonates and wait until a total hip replacement will become necessary. The results of hip replacement in 2020 are so predictable and so good. Thank you very much.